Hi there, Gary Bronze here, back to welcome you to the fourth episode in our series on kidney disease. Today, Dory, Melissa, and Jane are going to talk transplantation. If this is the first time that you're with us, welcome. And I'll tell you that the purpose of this presentation is really for you guys to be able to ask questions of the clinicians. So I'd only ask that you wait until the speakers are finished and we'll get into questions. At that time, you can either use the chat feature on Zoom, or you can simply unmute yourself and we'll do our best to provide answers to whatever questions you have, kidney-related questions, I should say. So let's get started here. Dory, you're batting lead off tonight. Let me see if I can share my screen. I'll pull up the slides and we'll get going. Okay, can you all see my screen now?
Yep.
Yes.
Great. This. Okay, Dory, take it away.
Hey, so I'm Dory Minch. I actually work at a transplant center, so I am very, very excited to talk about this, what I consider to be a very important topic in kidney disease. So I'm fortunate to work in a transplant program, and I don't think this philosophy is unique to our transplant program, but our philosophy absolutely is that everybody deserves a chance at an evaluation for transplant. And what that means is no matter what your background, no matter what your insurance background, your health background, your age background, we want to at least give you information on transplant so you can know if it's something you want to consider pursuing. It's important to remember that you should never rule out transplant as an option. All transplant centers have different age requirements, different weight requirements, different health requirements. Our transplant center will transplant somebody up to the age of 85 if they're in good health, up to a BMI of 45 if they don't have a lot of other comorbidities. We're a very liberal transplant center, and I want you to know, before I really get into some specific information, I want you to know that even if a transplant center says no to you now, it doesn't mean no is forever. I've worked with a lot of patients in the post-transplant.
Hi guys.
Hey.
Start? What? Yeah, we just started, but I go third. So, hello.
Can I tell you my spectacular bagel song?
Yes.
Bagels, bagels, I love bagels. When bagels are around, the sun is red, the sun is yellow. Bananas are yellow, bananas have spots. Spots live a long life. Look, that's my favorite too. It cost me $10. $10. That's crazy.
That way we can get on with the presentation. That would be great.
Rectangular, square, and all they can use bagels, bagels. I love bagels.
Girl, that's like the best bagel song I've ever heard. I think it might be the only bagel song I've ever heard, but it's the best.
So as I was saying, our transplant program really feels that, well, if a transplant center tells you no right now, it doesn't mean that no is forever. It just means that you may not be a good candidate for transplant right now. There might be something in your health that can be resolved. There might be something in your weight that can be changed that might make you a better candidate later. And there are a lot of people that I assess for transplant, and they've been on dialysis 4, 5, 6, 7 years. And I say, why is it now that you're coming to me? And they said, well, I didn't know I could. They told me I weighed too much, or they told me I had cancer and couldn't get a transplant, and I didn't know I could be reevaluated. And it's so important to know that when you are told, you may not be, if you are told that you may not be a candidate right now, that doesn't mean that's a permanent part of your health history. So I wanted to go through these slides in sort of a historical way, because the history of transplant is really very, very interesting. Someone somewhere decided that they were going to take an organ and put it into a new person and try to see if that worked. And this has been going back, I believe, ancient times that this really started. There was some documentation of some blood transfusions and stuff in Egyptian times, I believe it was. But in 1954, Dr. Joseph Murray performed the first successful kidney transplant between two twin boys. There have been previous attempts at living donation, but because of limited knowledge about blood matching and medications, they were not successful until Ronald Herrick donated his kidney to his identical twin, Richard, who was dying from chronic nephritis. Because they were identical twins, very little immunosuppression was needed. It was basically just a replication of Richard's own kidney being put into him. This milestone taught us that taking an organ from one person to another can not only save the life of someone with chronic kidney disease, but can also cause very little harm to the donor. Ronald, the donor, lived until he was 79 years old, working as a mathematician and engaging in his favorite hobby of haying and raising heifers, which was not easy work. Let's go to the next slide. And so the same team that transplanted the Merrick twins also performed the first successful deceased donor transplant surgery. A deceased donor transplant surgery is when the donor's loved ones, family, friends, decision makers agree that that the donor will be an organ donor. They were able to get enough kidney function for the person to stay off of dialysis. Well, many things have changed since 1962 when they did this first deceased donor transplant. Anyone who is interested in a kidney transplant needs to have a referral placed to a transplant center for evaluation. Some people are able to avoid starting dialysis and get transplanted first. If your GFR is 20 or below, you may be eligible for evaluation at a transplant center. Your nephrologist can tell you if you have any other health issues that you may need to fix before you become a good candidate, but taking steps now to plan for transplant, including health and the lifestyle choices that we've been talking about, may allow you to avoid dialysis altogether. After your transplant referral is accepted, you will be invited to an education class where you will learn about your program's specific policies and requirements to be a transplant recipient. You will meet with a financial team who will evaluate your insurance and your resources and let you know if there are any concerns with post-transplant costs. The next step will be meeting with the providers on your transplant team. This will include a social work evaluation to assess for support, transportation, substance abuse, legal history, and mental health history. You'll also see a combination of surgeons, nephrologists, PAs, or nurse practitioners who will look into your medical status, including making sure the transplant team can actually fit a kidney into you. There may be scans, MRIs, CTs, heart and lung tests to make sure that you are a healthy enough candidate for transplant. After your evaluation is complete, your transplant coordinator will present your evaluation to the selection committee, where it will be determined if a kidney transplant can improve your quality and quantity of life. Let's go to the next slide. So how am I going to pay for all this? Well, in October of 1972, the National End-Stage Renal Disease Program was created, and this extended Medicare benefits to cover the high cost of medical care for most individuals suffering from end-stage renal disease. This program recognized the importance of people with end-stage renal disease having health insurance and understood that not everyone is able to work all the time. If you need to start dialysis or you do get a transplant, you will be able to enroll in Medicare. Medicare has several different parts to it that cover hospital stays, dialysis, medication, including immunosuppression. There are many different people that can help you enroll and understand these benefits. Most people are eligible for these benefits based on their or their spouse or parents, if you're of a certain age, work history. Also, these benefits have a specific time frame that they'll start in, so you don't even need a lawyer to get them. It's an automatic entitlement. People who qualify for Medicare due to end-stage renal disease are able to work as well. There's a big fear amongst the Medicare population, especially the younger, that have Medicare due to a disability that's not end-stage renal disease, that they're not allowed to work, but this is not the case. As I stated, but just to really clarify, this ESRD program recognized that the health of dialysis and transplant patients is a bit precarious and can ebb and flow, and so they recognize that being able to provide an insurance benefit and expand the Medicare eligibility for this population not only helped the people receiving the benefit, but helped the healthcare system defray the cost of the dialysis. So how are kidneys allocated, and how do we hide these kidneys from our body? So UNOS, or the United Network of Organ Sharing, is a federally operated, nonprofit charitable organization that manages the nation's transplant procurement system. And so that's for all different organs. They operate 24 hours a day, 7 days a week, 365 days a year. And they will allocate the kidneys based off of a score that is given to the patient and a score that is given to the donor. And what they try to do is age match the organ to the donor. So if you're 16 years old, it's reasonable to think that you would want a kidney that would last maybe 50 years. So they would give a 16-year-old a kidney that would match 50 years. If our program transplanted an 85-year-old patient, while we'd love for them to live another 50 years, it's more likely that they would live for 5 to 10 years. So they would be allocated a kidney that would last 5 to 10 years. This matches organs better. It gives appropriate kidney function where it's needed based off of life expectancy. And it also lowered the rate a bit of the need for retransplantation because the kidneys were lasting longer. So when an organ donor is identified and the transplant center is notified by UNOS, UNOS will run the list of potential recipients from your transplant center. Transplant teams consider organs for specific patients, and once an organ is made, an organ offer is made to you, the potential recipient. So it's important at the time of transplant that you be free of infections or illness, have no medical problems, and that your blood tests confirm that you're compatible. So it's important to keep that testing up to date. You will be given some general info about the donor, like their age, their gender, the cause of death, their kidney function, tissue match, so that you can decide whether or not you want to accept the kidney offer. So in 1983, Cyclosporine was approved by the FDA as an anti-rejection medication. And when we talk about anti-rejection medication or immunosuppression, what that means is it's a medication that hides the kidney, the new kidney, from the rest of your body. And so your body doesn't come in and attack it to try to fight it off because it's a foreign substance in your body that you weren't born with. And the immunosuppression puts this bubble around your kidney so that your body doesn't know that it's there. And there is a delicate balance of making sure that you have enough immunosuppression so your body doesn't know it's there, but not too much immunosuppression. So if you think about a germ, you get sick. And that's a big balance in especially early stages after transplant. There are additional medication options today, including Prograf, Envarsus, Myfortic, prednisone, medications that you may hear. And because our bodies are designed to fight off germs and other things that don't belong, you'll need to take these medicines every day, like I said, to hide this kidney from your body. The importance of these medications was so vital that Medicare coverage helps to pay for a portion of your immunosuppression. And if you guys have questions about Medicare, that's another topic that we can talk about on another day. But in your financial evaluation, they'll make sure that you have enough coverage to pay for your medications. It's important to remember that you will need to pay for Medicare for about 3 years after transplant. And then after your Medicare ends, it's important to make sure that you have plans for insurance coverage to pay for these medications long term. Next slide, please. And so that brings us to now, sort of, skipping around a little bit. There's many new advances in kidney transplant. The fastest way to get a transplant is to find a living donor, hands down. This doesn't have to be someone who's related to you, looks like you, or even has a relationship with you. If you have someone who's interested in donating a kidney to you, let your transplant program decide if the living donor is healthy enough for you or a good match for you. Even if they're not the same blood type, they may be able to enter a registry where a kidney swap can be performed. This is when you have a donor that doesn't match you, and I have a donor that doesn't match me, but my donor matches you, and your donor matches me. That way we both get kidneys faster. It opens 2 spots up for people that don't have other people to donate. It's really important to tell your story. Many people don't feel comfortable asking for someone to be a kidney donor, but by telling your story that you could benefit from a kidney transplant, people may naturally say, hey, maybe I could be a match. Keep living donor contact information with you so that you can share it when someone expresses interest. Another way that you can get transplanted faster is to consider something called increased risk donors. And so an increased risk donor doesn't have anything to do with the kidney quality, but has to do with maybe some lifestyle events that the donors have had, maybe history of IV drug use or history of incarceration. All of these donors are tested for hepatitis B and C and HIV, and all of those testing will be negative when you're transplanted. The risk of transmission for hepatitis B or C or HIV is about 0.3% to get a kidney from one of these donors, but it decreases the amount of time you'll spend on a wait list exponentially. It's important to ask your transplant center too what other types of kidney donation programs they're doing. If they have internal kidney swaps for living donor, there's some questions and some opportunities for some blood typing that might be different that they can make exceptions for, and some other really innovative things that different transplant centers are doing that would be specific to your transplant center. So with that, I'm gonna let Melissa take it away. Oh, I'm sorry, Jane.
Okay, I'm sorry, I thought I was third. Thank you very much, Dory. I would like to say that we're very proud of our transplant program at UAB, and actually we have one of the largest chains at a single center in the country, and it was begun by a person who had no donor or no recipient in mind. She just had been hearing about kidney disease and came and said, I have 2 kidneys, I only need one, and I'm willing to give. And this was the beginning of our chain, and we've had I don't remember the numbers right offhand, but be that as it may. Next slide, please. So who gets a transplant? A lot of this Dory has already covered, but I think we can go over it again. Next slide, please. Who gets a kidney? A kidney transplant means someone gives you a kidney. It can be a family member, a friend, or a stranger. The donor can be living or can be donated after death. Your native kidneys are not necessarily removed. Most of the time, the native kidneys are left in unless there is a problem with them. It is really important to let people know that you need a kidney, which is what Dora referred to as telling the story. I have had patients, I had one in particular, she had a kidney from her father when she was a child, and she was a young adult and the kidney was giving out. So her best friend offered to give her a kidney and went through the testing and was not a match. But the best friend's sister, with whom my patient had not much of a relationship at all, she really hardly knew her, the best friend's sister ended up giving her a kidney. Next slide, please. So the requirements vary from center to center. Your kidney function has to be at a certain level. That's your GFR. Dory said 20. I believe our center is 18. Many centers have a weight limit. UAB's weight limit is less than Vanderbilt's. Now, I'm located in Birmingham. We have 2 good kidney centers 150 miles away in Atlanta. We have Vanderbilt, which is in Nashville, which isn't far, and we have University of Mississippi in Jackson. And I encourage my patients to list at many different centers. And again, some of the requirements may vary from one to another. However, people who have an active cancer are not listed. Remember, you're going to be on immunosuppressant drugs. That means that your body will be less able to fight infections. And the fear and concern is that if you have a cancer and you are on immunosuppressants, that cancer just looks at it like miracle grow for your yard. People who are using drugs that are not prescribed for them, drink a lot of alcohol or smoke heavily may disqualify. I don't know if they check for smoking or nicotine at UAB. I know the liver transplant people do routinely do blood checks for nicotine. As far as the non-prescribed drugs, I know there are some centers that don't ask as much detail as others. Patients are listed, once you have gone through the transplant evaluation, you're listed as either active, inactive, or not eligible. Now, active means that you are right there on the list waiting. But as far as the deceased donor list, at this time, there are more than 100,000 people in this country waiting for a kidney. So if you have someone that will give you a kidney or you get into the kidney chain, your chances are increased. Generally, people are put on the deceased donor list. Now, the inactive, you are still accruing time, but you may have some requirements that you need to meet. The evaluation for a kidney is very extensive. It is exhausting. Different centers do different programs, and I will say at UAB, and I'm sure at other centers, the transplant center offers several sessions of how to ask for a kidney, because asking someone to give you a kidney is a very difficult thing, and it is difficult for the person who is being asked also. Next slide, please. The screening process is long, thorough, and very tiring. At our program, you spend at least 2 days in a class. That's when you learn a lot of the details, and it's also where you go through a lot of the evaluations that Dory referred to. You see a social worker, a clinician who does physical exam, a psychologist who sees if you're mentally prepared to receive a kidney, and a pharmacist, among others. There is a psychological effect of knowing that you have some organ in your body that wasn't there when you were born. And it's sometimes difficult for people to think, well, someone had to die so that I could live, or what if this person who gave me the kidney, what if they get sick? And for that reason, the evaluation for the donor is about as stringent as it is for the recipient. We don't want to take a kidney from someone who is going to need it. We want to make sure that you are healthy enough for a kidney. And as Dory said, you are willing to follow up with medications and appointments. A kidney is a gift that is valued and valuable. Next slide. So when we talk about tests, there are just bukus. We start with blood work, and they draw a lot of blood. Then every month, at most programs, you have to send in some blood. This is to check for your antibodies. Getting a kidney and blood work is more than just type and crossing. It's more than knowing that you're O positive AB or whatever. There are a lot of antibodies and different things that they check on. Now, if you're on dialysis, the dialysis center receives the kit and draws the blood and sends it in for you. If you are not on dialysis, my patients just go to the lab and they draw it there. You have EKGs. Sometimes they recommend a cardiac catheterization. That's when they send a little tube into your heart to look around. If you're over 40, usually a colonoscopy is recommended. Dental exams are important because if you have gums that are not healthy, you can affect that kidney. We want your vaccinations to be up to date. Prior to the newest shingles vaccine, patients who wanted a kidney had to get their shingles vaccine before transplantation because the initial shingles vaccine was a live vaccine. Now it is a killed vaccine, so you can take the flu vaccine and the shingles vaccine if you need it. Females will need mammograms and pelvic exams with pap smears. And interestingly enough, you can have more than one organ transplant at a time. For example, patients who have type 1 diabetes often can get a kidney and a pancreas at the same time. Patients can get a liver and a kidney at the same time. So you just really have one surgery. Of course, it's fairly extensive, but you come out with 2 working organs. Next slide, please. So there are a lot of plans that need to be made. After a transplant, you're going to need help at home. Your team will tell you when you can return to work, when you can drive, and when you can resume other activities. And you have to take a lot of medications because, as Dory said, we're hiding the kidney, the new kidney, from your body. You may love your kidney, but your body does not. It sees it as an invader. That's why you take all of those drugs. And I will tell you, I have seen the delivery of those drugs really make remarkable improvements. For instance, cyclosporine, which was probably the first immunosuppressant after prednisone. Cyclosporine used to be given in a liquid form, and it was oily, and you had to mix it in orange juice or chocolate milk and keep putting the liquid in your little medicine cup until there was no more oil on it. So now it is in a capsule, and that's infinitely better. Next slide, please. So I do encourage patients to list at several centers. What is important is that you take care of yourself now, maintaining a good blood pressure, keeping your weight under control, and keeping other things under control, such as phosphorus. I have had patients who did not control their phosphorus as well as we wish they had, and they ended up having not being able to accept a kidney because their blood vessels were calcified. That is something that happens that you don't feel, you don't see, but they find it on ultrasound, and I think that is just tragic. The other thing is to be patient. Don't get discouraged. Kidneys come from interesting places, sometimes where you never expect them. It does take time, and unfortunately, we can't tell you it's 5 years, 7 years. I don't like to talk about averages because an average means half the people waited this long, half waited longer, and so they just take the average. The description to me of average is if you had a foot on a block of ice and a foot in boiling water, on the average, you would be comfortable, and there wouldn't be a part of you that was comfortable. It is essential that you talk to your team. And this is a patient of mine. He received a kidney from his sister, and he is one of the greatest people on earth. And I love him dearly. And that is a picture of me that was very seriously airbrushed. I hadn't looked like that since I was 20. So with that, I will turn it over to Melissa. Thank you.
Thank you, Jane. Thank you, Dory. And I apologize. I don't normally have kids with me when we do these presentations, and they got here, and my 7-year-old wanted to sing me her bagel song. So I apologize if there was some background noise on my end when we began. So the next slide just goes through the points that I was going to cover today. Really, these are just some of the changes that you might want to consider for lifestyle changes after receiving a transplant. So we'll start first with diet and exercise. On the next slide, please. Okay. So as it states on this slide, we want to make sure that we're still continuing to follow any other condition-specific recommendations for any other conditions. So continuing to follow a low sodium diet for blood pressure management, making sure that we're keeping the blood sugars in check and following an appropriate diet for diabetes management, heart healthy fats, and so forth. So we want to make sure that we're keeping these conditions managed and in check for overall health, but also to ensure the health of the new organ. Some of the transplant medications that Jane was talking about, some centers prescribe steroids, and these may cause increased hunger. It may cause increased weight gain from that hunger, and it can also cause increased blood sugars. So it's important, kind of keeping all of the disease management in mind and working with your providers to keep those levels in check. Now, what a lot of patients will comment on post-transplant is the increase in fluid intake. And this is particularly true for those who are on dialysis and have been restricting their fluids, that now with the new kidney, we want to keep the kidney healthy and hydrated. And so we end up drinking a lot more fluids post-transplant. So I actually have a family member who received a kidney transplant. And every time I see him, he tells me about how much water he's drinking and all of the good things that he's doing to keep his kidney healthy. And then exercise. A lot of patients after transplant have more energy and they're feeling better and they're feeling like they can be more active. And so when they're healed and have that okay from their provider, many patients can resume exercise programs. Next slide, please. So I wanted to talk a little bit about the immunosuppressive end of the medication, in particular when we're looking at the diet. So the medication is there to help the organ not be rejected by the body. It's suppressing that immune system, where your immune system, if it wasn't being suppressed, it may attack that new organ since it's a foreign body, but then it also puts you at that higher risk for infection and illness. So food safety actually is a big part of the post-transplant diet plan, which is not really part of the diet, but it's more of just the kind of overall nutrition aspect when you're thinking about cooking or if you're going out to restaurants and so forth. So raw fruits and vegetables, sometimes we want to make sure that we're washing our fruits and vegetables, not with soap and water, but we want to rinse them off in general, all of our raw fruits and vegetables, because there are sometimes dirt and other organisms on there that we want to make sure we don't ingest. But if your immune system's compromised, you may be at higher risk then for foodborne illness. So that's safe handling of food, minimizing the raw fruits and vegetables. If it's a cut fruit and vegetable and you're out somewhere, kind of ones that are already sealed and packaged would be better. But then it's also keeping in mind the 4 steps of food safety. So this would be something else that someone who's received a transplant would have to be mindful of. And those 4 steps are clean, separate, cook, and chill. So cleaning just meaning that you're keeping your kitchen area and your utensils that you're using clean. Obviously talking about like the raw fruits and vegetables, just rinsing them or using a fruit or vegetable brush to scrape off any of the dirt on the outside of them. For separate, we want to make sure that we're keeping raw and cooked foods separate. Cooking, we want to cook our foods to the appropriate temperature, the internal temperature. And then there are steps for chilling our foods for storage. So keeping these things in mind to really minimize that risk of foodborne illness. And it's particularly important in those early stages just post transplant. So those initial months, we want to really be very mindful of that foodborne illness risk. And the other thing are dietary supplements. A lot of the medications are not, the dietary supplements are really not indicated to be used with some of the medications. There could be some interactions. So for a lot of patients, they're really advised to not take dietary supplements or at least really minimize them. So if there are any questions, if there are supplements that you're taking or you want to take, you have to make sure that that is being reviewed and discussed with your provider and pharmacist to really make sure that there's no risk to the kidney for taking them. Next slide, please. So mental health, I think a lot of people might think I have a new kidney, life is amazing and it's wonderful, and it is, and it should be. But some patients may also feel stress or anxiety post-transplant, and there are many reasons for that. So I've listed some of the reasons on this slide, but like any changes in life, receiving the gift of an organ is a lifestyle change and something that you need to adjust to. So you want to make sure that during the transplant process, when you're working with the transplant team, that you're talking about what life is like post-transplant, connecting with the professionals at the transplant team and making sure that you have some plans in place and a network in place when you are through the process in case any type of anxiety or depression occurs. Next slide, please. So these are some of the other lifestyle changes that you might be thinking about with the transplant. So returning to work. If going back to work post-transplant is desired, oftentimes the transplant team may advise you to wait 3 to 6 weeks after surgery. So you may be given limits on what you can do at work, at least in the beginning, while you're still recuperating. And if you need to find a new job, kind of working with the transplant team or career counselor to kind of work with you and kind of connect you with that. But many patients are able to return to work. You just have to be sure it's within an appropriate time frame so that your body can heal post-transplant. For traveling, now, patients are feeling better, they have more energy after transplant, and they want to take a trip. So some transplant teams may ask that you wait about 2 to 3 months before taking a major trip. And you always want to talk with your provider about anything that you should consider before traveling. For example, getting enough refills of your medications to make it through the whole trip, any considerations to think about to minimize the risk of illness. If traveling outside of the United States, talking with the transplant team about vaccines or shots that might be needed, food to stay away from, and the safety of drinking water. And I believe I want to say it's the FDA. I would have to actually go check that. But there was an app a few years ago that went through, and it would say if you were in Italy, for instance, or if you were in Portugal, it would say these are the foods you should stay away from for food safety concerns. These would be good choices. So there are some online resources available for that, and I do believe that was from the FDA or CDC. But you want to kind of just think through about what foods you really want to kind of be mindful of. A lot of times the raw, like salads, fruits and vegetables, those always seem to be on the list of foods that you want to be mindful of when you're traveling outside of the United States. And then obviously the safety of drinking water, depending where you're going to be. And your doctor may suggest waiting, as I said before, you know, 2 to 3 months for, you know, a major trip, but possibly 6 to 12 for traveling abroad. Driving, again, you'll get the go ahead from your provider, but you can start driving, you know, oftentimes within a month, but could be a little longer. So again, that would have to be cleared by your provider. But there are some reasons to delay that. Some of the medications that you have to take right after transplantation may cause some vision changes that may affect driving. So you want to just make sure that everything is okay before getting behind the wheel again. And then with relationships, you know, again, if there are any mental health concerns or things like that, you want to make sure that you're working with a professional that can kind of help guide you through that. But oftentimes your provider will kind of talk through when it's appropriate to start intimate relationships again, and so forth. So this is the last slide, and this one's really just kind of a summary about keeping that new kidney healthy. So we've talked about the medication, and that medication again is very, very important to keep the kidney from rejecting, or to keep your body from rejecting that new organ. So it's very important to keep taking your medication as prescribed. If you had to miss a dose or something happened, it's important that you follow back up as soon as possible with your provider to kind of talk through what should you do. If you're feeling ill or notice an infection, to contact your health provider. Again, being on immunosuppressant medication makes you higher at risk for illness and infections. And so it's very important to make sure that you're contacting your provider as well, because sometimes those can become more serious. And then also to stay healthy, avoiding being around others who are ill. So you might have seen a lot of this with the current pandemic situation and COVID, and we're making sure that we're social distancing. And that's incredibly important for people who have received organ transplants. And as I said before, we're increasing the amounts of fluids that we're drinking. So we want to keep the kidney healthy and hydrated. We want to always continue following a healthy diet, but we also want to make sure that we're kind of monitoring our weight. Weight gain can tend to be a concern post-transplant. Patients are eating better, they're feeling better. And as I said before, some of the medications may cause you to eat more and put on some more weight. So we want to make sure that we're following a healthy diet and being mindful of not adding on weight, and then as able and when given the okay to resume exercise and activity. And I believe that's it for me.
Thank you very much. Let me see if I can get my screen back. There we go. Okay, we're back. So this is the part of the program where you guys have an opportunity now to ask some questions, and you can feel free to unmute yourself and ask away. Otherwise, there is the chat feature in the bottom of Zoom, so you can always use that. And we're happy to try to answer any questions that you have, any kidney related questions that come up. So let us know. Nadia, you have a question?
I have two questions. So it's kind of about the diet that, or two things. One, I heard you talk about the shingle shot in there regarding the transplant. Is that for transplant patients only, or are people with kidney disease supposed to get the shingle shot?
Actually, Nadia, I think you're too young for it.
Okay, just wanted to double check. I like to keep up on all my vaccinations.
No, it's usually for people who are 60 or older.
Okay, very good. And my second question is, my mom, who's a diabetic, I cook for her. So she's trying to keep up with her kidney health as well. So I take all my information back to her. And she soaks her food that has any kind of sodium in it, such as processed meat and things of that nature. How much sodium does that take out of the food?
So it really just depends on the food. I would say most of the research has looked at like potatoes was kind of, I think a lot of the research has looked at how much are we actually getting. And so there's like the double boil method where you're soaking your food for the potatoes for a long time, and then you drain them and you soak them in more water and then you cook them. But you can do that. It's kind of like dialyzing your vegetables. So most of the research that I've seen in that looks specifically at vegetables more than, so what other foods is she soaking?
So it's like hot dogs. I would soak them overnight for her.
No, it's the soaking of the vegetables is for potassium.
Right, I'm sorry, potassium, not sodium. I apologize. It's
So
potassium.
I don't think anyone has done any
No,
studies
not for sodium.
on the sodium. So there's really, I couldn't even begin to guess if you could get the sodium out.
Okay, so it's best to just find low sodium or not to eat the processed food.
Correct. Yeah, if she can eliminate the processed foods, I mean, that would be the first thing. And then I would say to, just try to have the lower sodium ones if possible, but really try to eliminate all the ultra processed foods, would be the most appropriate. And then things like if you had like a canned food, like a canned vegetable, right, that has salt in it, we usually recommend to drain those and rinse those because that will remove some of the sodium.
That we do.
Yeah, the soaking is more like, is potassium. Sorry, my brain is like not here, but it's potassium.
The draining and washing of the vegetables, you're washing the surface off. The problem with hot dogs is it's all the way through.
Okay. So just washing in the vegetables, that will wash the sodium off. But the problem with the hot dogs that it's already through.
Yeah.
Just a little bit. There's still going to be salt in there because remember, salt kind of attracts things. So there's still going to be some salt in like vegetables. I'm not talking about hot dogs. I'm talking about vegetables. So like hot dogs are going to make it with salt. So food that's made with salt, like bread and hot dogs or things where they put salt in when they're making it, cookies, all those kinds of things, that doesn't get washed off. But if you have like added salt in the water and the brining on like the vegetables, you can wash some of the salt off, but in reality, it's still going to have salt in it. So you want to try to choose the no added salt options if possible. Yeah.
Reading your labels, which I know you do, and comparing brands.
All right. Thank you very much, ladies. You've been very helpful with my shopping and my eating.
Okay.
Does anybody have any other questions for us?
Yes, could you go over the core comorbidities that can make you ineligible for a transplant?
We can, and I want to say that they're often specific to each transplant center. But things like an active cancer, meaning you're being treated for cancer, an active substance abuse problem, an active mental health issue. There could be some cardiac issues that could be considered absolute contraindications, but that would really be up to your transplant center. And those couple of things that I've mentioned, those are reversible. So we've transplanted people who have been cancer-free for X amount of time, depending on the type of cancer that they have, or who had, I evaluated a young guy who had just stopped using heroin and came in for an evaluation. And so while I was really happy that he stopped, we wanted him to sustain his sobriety because transplant can be very stressful. So those things are reversible and those things aren't permanent. I don't know, Jane or Melissa, if you're aware of more of the medical contraindications, and I'd be really careful to even say what they are because they're going to be specific to your transplant center.
Correct. I mean, they're going to make sure, for instance, that your heart is healthy. So those are what we mean by comorbidities, but that is something that your transplant center determines and you will learn about in the transplant evaluation.
And another thing that's important too is we'll evaluate patients and they'll have a cardiac workup in advance, sort of separate from transplant, and they'll tell the patient, oh, you're not a good transplant candidate because your heart's not good enough. But then they come into the transplant program and we do our own little workup, and the concern that the cardiologist had isn't quite the concern that our transplant team has. So I think it's really important, I'm trying to just go through here, I think it's really important to make sure that you're talking to your transplant center and find out what their specific contraindications are. And if there's one at one center and there's another center relatively close that you could engage in your follow-up, try going there. You know, we transplant a lot of people, and we're sort of kind of known in our state as, well, if we can't get transplanted at such and such, send them over to Baptist. They'll probably transplant them. And it's typically the case. And like I said, our team just really feels strongly that people at least deserve an opportunity at transplant. And I think more times than not, we've been rewarded with success, and the patient's been rewarded. And we get burned a couple of times, but I think overall, really our outcomes are pretty good, and our patients really appreciate the opportunity that we give them and really honor that opportunity.
Okay. I do have one other question. I really don't know if you can answer this one, but how do they go about setting your weight limit?
So every transplant center, at least within the Chicagoland area, they have some slightly different criteria. So, you know, I don't know how, you know, Dory, your center does that, but I know that, you know, the various centers that I've worked with in terms of just like community partnership and patient collaboration for the referral process when they're working up, it just kind of depends. So, I mean, I've had a patient who was maybe a BMI of 38 and they wanted her to lose weight before she was considered for transplant. But then there's been other centers where they were over a BMI of 40. So I think it kind of depends on some of the workup and their actual criteria in the center. I know that there's one center in Illinois that actually does bariatric surgery with the transplant. So they have a whole other set of criteria. But I don't know if there's like a national standard. I know that each of the centers are just a little bit different in how they do it. So Dory, I don't know, how does your center?
We will evaluate someone with a BMI of 45, and we say that we won't transplant above 40. That happens though. And the other piece too is where you carry your weight, you know, so when they do your scans and they're looking at where like your iliac arteries are and where your kidney's going to go, they need to see, you know, how much tissue that they have to get through to get that kidney. And part of it really is surgical healing, but how much they need to get through to get. So if you have a BMI of over 40 and the surgeons can see clearly, oh, well, you carry all your weight in like your rear and your legs and your stomach's, you know, pretty flat. You know, if you lay down and your stomach sort of drapes to the side and doesn't like stick up like a beer belly, so to say, is what our team calls it. But you may be a better candidate even if your BMI is over what their limit is. And the thing is you just got to get your foot in the door, and you just got to get them to look at you, really. You know, so getting in for an education class and just asking for an evaluation. And you know, I know that wait times are long in different states, but being evaluated for a kidney is not what makes wait times long. It's the amount of people that are on the list that need a kidney is what makes wait times long. You know, and we have patients that will be evaluated and have something that they need to work on, but they may have a living donor in the wings, and they're just working up their living donor, and as the living donor is going through the workup, the patient's working on weight loss or smoking cessation if that's a requirement, or sometimes we have our patients do prehab, because the last thing you want to do after transplant is go into a nursing home just because it's full of infection and you're immunocompromised. So we might have someone to do what we call prehab, which is, you know, just working either with an inpatient or an outpatient physical therapy program to gain some strength so that you're in a better spot after transplant while your living donor is being worked up. Sometimes you can, depending on what's going on, they can list you as what's called a status 7, which is you're accruing time on the wait list, but you're not going to be called in for a transplant. So depending on what your health issue is or what your issue is that's preventing you to be fully active, they may be able to make you inactive on the list so you can gain wait time on the transplant list. And that's kind of where it all starts, is with that wait time that you need to gain.
So the transplant center will tell you what you need to do.
Right.
And there's a chain of restaurants, it's out of Texas, it's called Chewy's. And when you walk into a Chewy's, there's a big sign that says, if you've been to one Chewy's, you've been to one Chewy's, because they're all different. Well, the transplant centers are the same. If you go to one, you've been to one. I know of a center that never asks patients if they smoke marijuana, and I send a lot of people there. I know there's a center that has a less stringent weight requirement. I send folks there all the time. So every center is different, and we really can't tell you that's it.
But what we can tell you is if one center says no and you have an opportunity to go to another center, go to another center. And if one center says yes and you get through and you're listed on them, then still go to another center.
Exactly. But they will tell you why they're saying no.
Right.
And you do have time, because it's not like you go through evaluation on Monday and they call you on Friday. It takes time.
Can I ask you guys just to describe BMI? You mentioned BMI a few times, just for the folks that are watching.
BMI is body mass index, and you can Google it. It will tell you your BMI. It's a guide, because, say, for instance, someone who is very muscular may weigh more, but you put in, you just Google BMI or body mass index, and it will ask you for weight and height, and then it comes up with a number. 20 to 25 is ideal. 25 to 30 is considered overweight. 30 to 35, I think, is considered obese, right? Dory, Melissa?
Yeah. So 19 to 24.5 or 9 or whatever is normal weight, or it's like 18.9, and then you've got 30 to like 35 is obese, and you have like the 25 to 29 would be overweight, and then 35 it's obese 1, 35 to 40 is obese 2, I think. Super obese is over 50. So there's like different classifications, but I mean the research with it's a little flawed. It's really like Jane was saying, more of a guide. People that come from Asian backgrounds tend to be on the lower end to almost the underweight BMI part of the scale, but that's normal for their frame size. And then you have kidney patients where we actually like them to be, like particularly dialysis patients, in more of the overweight category, because there's a little more protective for them. And if you're muscular, so it's really more of a guide, and it's kind of the overall evaluation of what's going on with you in terms of, the transplants and if they're going to transplant or not. So it's kind of like a one criteria, but like Dory was saying, it kind of just depends how all the other factors go in, whether or not they're going to go off of that. And so each center is a little bit different on that, but it's basically your height. So it's kind of like you can either do it in pounds or kilograms, and there's a little formula to it divided by your height, and there's a number that they come up with. So there's there's online calculators that will do it for you, and then there's like charts, and it'll let you know like where you fall within that. But
But don't be the one to rule yourself out. Let the transplant center decide that. And it's the same with your living donors, or any living donor. Don't be the one to rule them out. Let the living donor program at the transplant center make that decision, because you may be surprised. You may, somebody may have a living donor that isn't a good candidate for them, but maybe a great candidate for somebody else. We had a young girl, she was 15, she needed a kidney. Her dad matched. He was an older guy who was about 60. And they didn't want to give a 60-year-old kidney to a 15-year-old because it really wasn't just going to last long enough. And so they did a swap where there was a younger 25-year-old altruistic donor who donated to the daughter, and he donated to another person who just was randomly waiting on the list because it started with an altruistic donor. So even if you feel like your donor may not be good for you, make sure that let the transplant center talk to them, because it's up to the donor if they want to maybe donate to somebody else or do something like that. So it's really driven by the transplant center, but you can come up with all these things in your head as to why this would or wouldn't be good for you. But at the end of the day, it's up to the transplant center, and you may be surprised in a really pleased way.
Thank you, guys.
Anybody have any other questions for us? Well, I hope that the presentation was helpful to you, and I want to remind you that we have 2 more episodes in the series. So I'll encourage you to join us again next Wednesday at the same time. We'll be learning about home dialysis. I want to thank again Dory, Melissa, and Jane for lending their expertise and being so generous with their time on these sessions. Really do appreciate it. And I'd like to say a special thanks to Telegen for their support. And now on behalf of the National Kidney Foundation, I would like to wish you all good health. I hope you have a great week.